Hi guys. Thanks for joining me today. I'm glad you could be here. I want to talk about our patient John we had here recently. He was a 55-year-old man in the ICU, and he was admitted there with massive hemoptysis. Now, when he arrived, he was prescribed sequential compression devices for VT prophylaxis. And after a week, his bleeding was under control and had been for that week, but he remained in the ICU for persistent fevers. So while in the ICU there, the bedside venous Doppler ultrasound revealed that he had multiple deep as well as superficial venous thrombi in the upper and the lower extremities. So at this time, the CPOE was placed in order for continuous heparin, and it was dosed based on weight. So after 4 days, APTT was continued to be subtherapeutic, and this was despite the titration of the dose up to 44 units per kilogram per hour. So he's on a very high dose. Now, the anti-factor 10A levels were also tested at this time, and this confirmed that the patient was supposedly having a subtherapeutic dose. Now, after that, over the next several days, the APTT was continued to tested, and it rose over those days and eventually hit the therapeutic range. And so at that time, the heparin was titrated down. So looking through these series of events here, the two things I really seemed to notice was one, our patient had controlled bleeding, but was still immobilized. His bleeding was controlled for a week, but he was immobilized. So he should have been on some kind of a heparin or some kind of chemoprophylaxis, but he wasn't. And then we got a super high dose of heparin once he was finally initiated on therapy. And I feel like something could have been done there. So, and what are you guys' thoughts?
I agree. Like you mentioned, the patient, he was being extensively evaluated in the ICU, but he still did not have pharmacological prophylaxis of his DVT for about a week after his bleeding was controlled with embolization. So our protocol for evaluating patients, it doesn't include the timing for initiating DVT prophylaxis with pharmacological agents. We need to clarify this in the protocol.
Okay, excellent.
Okay. And from the nursing perspective, we were extremely understaffed that week. We had a nurse move, and we were currently training a new nurse. During the time of the event, we had a nurse call out, leaving the floor understaffed. The nurse in charge of setting the pump was overwhelmed trying to care for her patients as well as someone else's. That led to overlooking the patient and a potential mishap with the pump.
We do check our pump quarterly to make sure that they're properly functioning. It was checked last week and was shown to be working efficiently. It leads me to believe that it was a human error. The nurse probably programmed the pump manually instead of using the drug library settings. So we did go back and we checked the pump, and it seems that instead of inserting 44 units, she used 4.4 units. If she did use the library settings, the pump would have alerted the nurse that the dose was outside of the normal range.
Okay.
Alright, so it sounds like from all these problems, like ways that we need to fix it, we need to implement a protocol in the ICU for daily assessment to include the thrombolytic prophylaxis assessments to ensure that all our patients in the ICU are assessed daily. In terms of our nursing staff, we could create a on-call schedule for nursing staff to help alleviate when we have unforeseen circumstances arise, to ensure that all our patients are cared for and the nursing staff are not overstressed. And then also for pump use, we need to make sure that all of our employees are trained efficiently in how to use the pump and how to correctly use the pump. So what we can do to make sure that all of these actions are going to be going through is we can audit the thromboembolic events in the ICU in the next 6 months compared to previous events. And for nursing staff, we can audit the nursing schedules to make sure that we're utilizing the proper amount of hours compared to how many patients we have on the floors, and how many nurses we have available as well. And then also for pump use, we can continue monthly audits of our nursing staff to ensure that they are using the medication libraries instead of manually entering in those entries to reduce the pump errors.
Excellent. Sounds like three quality ideas there. Is there anything else anyone would like to add?
Sounds great.
Solid.
Excellent. So let's get these protocols implemented, and we'll make sure we follow up on everything, and we'll be back in a few months, see how everything's going. Thank you very much.